biology at McGill, and she holds an interdisciplinary PhD in medical genetics from the University of British Columbia. She held postgraduate fellowships at Yale, Memorial Sloan Kettering Cancer Center, and the University of Toronto. She currently works as a scientist at the Keenan Research Center of the Li Ka-shing Knowledge Institute at St. Michael's Hospital. She's a professor in the Institute of Health Policy, Management, and Evaluation within the Dalla Lana School of Public Health. She has leadership roles in and contributes to many advisory boards involving genetics, prenatal screening, cancer care, and health equity and social issues. And she's published extensively in all of these areas. So please join me in welcoming Yvonne Bombard.
Lovely. Thank you for that lovely introduction and the invitation to come, and for all of you for coming in today to hear about my life's work and journey thus far. And hopefully the conversation today will spark some new thoughts on where I go next. So thank you very much for that lovely introduction, Michael. Let me take a step back and maybe introduce myself a little bit as to why I'm here today and why I've chosen to do this work. My life's mission is to try to increase the access to precision medicine and the outcomes for patients. When I was a first PhD student in my first year, I had spent some time in the genetic testing clinics here at North York General Hospital and in Vancouver, trying to identify what I was going to do for my PhD. And I remember quite vividly sitting in the consultation office of a psychologist, speaking to a patient who had tested positive genetically for Huntington's disease, but was not exhibiting any symptoms. This was pre-symptomatic predictive testing. And it was fascinating to me as to why people would learn this quite devastating disease decades potentially before the onset of symptoms, when in fact there wasn't anything we could really do medically to help this person and their families. So I remember my PhD student supervisor at the time saying, why don't you just hang out at the clinics and find out what the issues are at the front lines and figure out what is important to you to investigate going forward. And so back to that encounter, sitting in that office. And I remember vividly this gentleman, maybe in his 40s, coming back to a psychologist. It was a multidisciplinary clinic for Huntington's disease predictive testing. And I remember quite vividly that this individual was articulating a situation at work where he had disclosed, because of a perceived fiduciary obligation to do so, to his employer, I come from a family history of Huntington's disease. I've chosen to undergo predictive, pre-symptomatic genetic testing to know if I carry this gene mutation that will predispose me.
I can't get the headphones to work. I don't know what the fuck.
Well, he said the sound is very
I
weak.
know, but I can't see. I'm not getting anything in the headphones.
Oh,
Nothing.
Oh,
I don't know why.
oh,
Hi,
okay.
Jack. Can you mute yourself, please?
Oh.
Lovely. Welcome. And I hope it's working for you. So let's go back to that clinic encounter. So he decided to disclose this mutation,
Did you
this
mute yourself?
molecular diagnosis, not a symptomatic diagnosis. And he had proceeded to share the fact that he slowly over time was subjected to changes in his work environment, taking away responsibilities from him over time, and then trying to change a position or two over the last couple of months, and he'd been denied. And he was complaining to the psychologist saying, you know, what can I do about this, doc? And I remember quite distinctly just being floored that this was happening. And I ran to the bathroom stalls and I called up one of the leading legal scholars at U of T, Trudeau Lemons, and asked him, Trudeau, I know that you've been doing research in this area. Are there protections for Canadians, for patients against this form of discrimination? And he said, Yvonne, this is called genetic discrimination. I've been trying to tackle this in the insurance domain. I don't know about the cases in employment, but no, there is no protections in Canada against this. And that moment, I realized that that was going to be the project that I was going to start my PhD. And going flash forward, I conducted national work to essentially provide evidence that this is occurring in Canada, because the predominant assumption was there's universal health care. We don't have to worry about genetic discrimination in Canada. And so that was the first glimpse into this wild west of us moving the needle scientifically and medically into precision genetic genomic medicine, but not having the concurrent guardrails societally to usher this in a equitable, responsible way to support society, frankly. And that's how I started my career. And over the next couple of years and decades, I went on a circuitous route of interdisciplinary training to essentially cobble together disciplines in health policy, public engagement, health services research, cancer genomics, and amass the kinds of expertise that would then allow me to start developing the evidence, the policy, and move the needle on equity. So that is where I am, where I've come from. And I'll take you on a little bit of a journey as to some of the issues that I've tackled over the last couple of years to try to move both medical and societal worlds responsibly to be able to deliver and adopt precision medicine in an equitable fashion. So let's take a step back at being one of those patients or people in the world that are now being offered not only predictive genetic testing for one gene, but now we're at the point where we could be actually sequencing or screening a person's entire genetic code, their genome. And imagine, if you will, that you're being offered the opportunity to peer inside your genetic code into your genome, where we unravel every gene and be able to read and learn about every single potential disease risk that you're at risk for. Your risk for Alzheimer's disease, early onset brain conditions, cancer, heart disease, diabetes, and the list goes on. Early on, this used to be considered forms of Gattaca, but this is no longer science fiction. It's actually very much both available, both in the consumer world as a 23andMe genetic test offered for individuals to spit in a kit, pay for it, and recreationally learn about their genetic predispositions, or very much in the clinic, where we are not just testing one gene or several genes at a time, but now the economics makes it actually quite equivalent to just screen an entire genome of a patient or a person to identify the risks that we're looking for, but also the disease risks that we might have not necessarily been out to learn about, but we stumble upon incidentally. So again, genomic sequencing, just to highlight the fact that we're looking at the entire genetic code of an individual, and we're mapping it or sequencing it to essentially reveal these disease predispositions. Predispositions for all these forms of diseases that I've described, some of which have medical interventions or social interventions, many of which do not. And again, to put this into practice, what can we do with this information? Well, primarily we're using it to diagnose disease. Whether that person, for example, comes into the clinic with cancer diagnosis. Now, clinical practice guidelines expect oncologists to order sequencing of the patient's tumor to identify drug targets, to obviously treat the tumor, but also increasingly we're pairing that sequencing of the tumor with sequencing of the genetic code of the germline of the person's constitutive DNA in their blood as well, frankly, just initially as a way to just reduce the artifacts, the noise, and identify the specific targets of the tumor that don't present in the patient's bloodline, for example. It's an analytic process to just essentially identify the needle in the haystack without having to read the genetic code of the entire haystack, if you will. But in addition to diagnosing a person's disease or identifying drug targets, we're also, because inherently revealing and mapping the entire sequence of that genome, able to identify other disease risks for other either current or future predispositions for disease. This is helpful because we can also identify, for example, if someone holds a BRCA BRCA1 or 2 mutation, and this is a prostate cancer patient, we know that if that prostate cancer patient actually harbors in their bloodline the BRCA mutation, then that will actually predispose them to a more aggressive form of prostate cancer, but also one where there are specific drugs like PARP inhibitors that would actually be useful to apply to that individual so that they can actually have a much better outcome. There's also opportunities in the world of pharmacogenomics, which might be familiar to some of you, where we know that there are certain medications like warfarin, Coumadin, codeine, where if particular individuals harbor gene changes, variations, that they will either metabolize those types of drugs faster or slower, or have severe side effects to those drugs. And we need to identify those individuals before we put them on the drugs so we can drug dose them appropriately so that they don't essentially, in the case of warfarin or Coumadin, stroke out or bleed out. But inherently, we're talking about inherited disorders as well. So what is found with one individual might create risks for other members in their families. And this, of course, has very weighty and psychological implications, both for that individual who has been genetically tested and is now in a place that needs to share that and essentially drop a bomb on the rest of their family, but then identify the fact that you now need to get genetically tested as well, because if I have this mutation, there is a chance that you also do too. And I had cancer, but there is possibilities if you have this mutation that you can actually undergo screening and surveillance early and avoid my fate. But there was an issue, as I intimated off the top, that there was a surprisingly low uptake of genetic testing in the clinic. And we were scratching the heads as to why. Why would individuals, if they know that they have this family risk for Huntington's disease or very frequent cancers in their family, why do they not choose to undergo genetic testing? Well, in fact, the number 2 or 3 reason in the global surveys was because of the fear of how these genetic test results were going to be used against them by third parties, like insurers or employers and what have you. And at the time, circa 2021, 22, there was a debate. Does this really matter in Canada? Are we protected because of our universal healthcare system? And you can see that there was a debate in the Global Mail on the front page as to why we need legislation, why we won't need legislation. And this was continuing. But this was continuing in a vacuum of actual evidence to suggest whether this was a problem or not. So I undertook as I mentioned, both a qualitative interview study across the country in order to be able to understand what are the lived experiences and issues for families. And in this particular study, I focus on Huntington's disease. Again, because Huntington's disease, as many of you might appreciate, is caused by one gene mutation. And if you are shown to have that mutation, then unless you're hit by a bus, there's a 90+ chance that this will develop in your lifetime. And the question is when and to what severity. While that is extremely sad and potentially disempowering information from a scientific experiment to understand this social issue of genetic discrimination, it became a controlled experiment because it was one mutation causes one disorder, And if we need to understand, is this causing insurers or employers or other third parties for discrimination, it created a very tight experiment for me to be able to control all the other variables that might be at play, especially in cancer. There's many genetic mutations causing cancer. There's many environmental risks that can increase or decrease your risk for cancer. But Huntington's disease was this unique, extreme case study for me. Beyond which I just fell in love with these families as well. So I was passionate about trying to support them. So I undertook a qualitative study to first appreciate what is the issues that they're experiencing. And I went across the country, interviewing both individuals who had been pre-symptomatically identified and tested to harbor these mutations, those that tested negative, and those that chose not to test. They have a strong family history, but because of this issue and others chose not to test. And then I created a survey in collaboration with collaborators around the world in Australia, the US, UK. So we had one measurement tool to be applied across the world. And in Canada, I led the study across Canada to ask fundamentally, have you experienced this form of genetic discrimination? What areas and why? Was it the genetic test result? Was it your family history? Was it some other reason? So the first very surprising finding was that, in fact, 40% of individuals across the country that were sampled for the survey who were asymptomatic, confirmed diagnostically by neurologists that they were not exhibiting any symptoms, and thus any of their reports were on the basis of either family history or their actual genetic test. So first, let's just put 40% into context. The psychologists in the room and otherwise might appreciate that when we're talking about a rare or common incidence, we're talking on the order of less than 10%. So by all interpretations, 40% is actually common. And when we actually unpacked where patients and not patients because they were asymptomatic, where these individuals, the survey respondents were reporting these incidents of genetic discrimination, well, in fact, insurance was the most highly rated area in their life where they were experiencing this. But surprisingly, family and social settings were the next two areas where they were experiencing genetic discrimination. Healthcare among their doctors and allied health professionals, employment, and government. What does government mean? The Canadian forces within the within legal proceedings for custody and access, for example. So back to policy. I'm an evidence-based medicine practitioner. Those of you that practice or clinically have or did practice clinically, you appreciate the fact that we subject our drugs, devices, and technologies to a high evidence standard before offering them to our patients. Well, the same should be true of the way that we make public policy and health policy in our country. And that after this publication of the work that I had led, both the CCGF, the Canadian Coalition for Genetic Fairness, started to an advocacy group of disease organization and patient advocacy groups came together and assembled, recognizing that whether this was a Huntington's disease issue, cystic fibrosis issue, Canadian Cancer Society came, the Foundation for Fighting Hereditary Blindness, about 20 to 25 disease advocacy groups, patient communities came together under this auspices of the Canadian Coalition for Genetic Fairness, energized to start to move towards and recognizing that precision medicine and the onslaught of both these targeted therapeutics and these diagnostics are coming for their patient communities. But if we don't have protections in place, then we're going to be creating a major barrier to the potential benefits that we can be offering to our patients and those families. So the Canadian Coalition for Genetic Fairness, and I was their scientific expert. And wow, that was a first-hand experience into public policy in the making, or maybe the sausage making in the process of that. But what I learned was we need to find MPs and MPPs, member of parliament and member of provincial parliament, to start to sponsor these bills, these private members' bills. And way back in 2010, Judy, who was the MPP or MP for Winnipeg North, found this to be her calling and sponsored a private members bill that unfortunately came and then died on the order table. Then another private members bill several years later, or in the same year actually, this particular one was read in the House of Parliament, but unfortunately also died. And then another one by some other wonderful MP came 2 years later and again died when Parliament was prorogued. So this was, I mean, a sad but very poignant understanding of how policy is made and how we need to pivot to make this happen. So then came Jim Cowan, member of Parliament from Halifax, who was about to retire but made this his swan song to find a way to pass some form of genetic discrimination law in Canada. And this was the famous Bill S201 that was written, rewritten, and then debated with various lobby groups that supported insurers, the insurance companies themselves, and we went across the country to get as much both buy-in, but also hear the issues as to why various industry members had problems with this. And we would work with them, and he would work with them, and his wonderful policy advocate, Barbara Koenig, who also essentially sat down and tried to edit the actual bill to make sure that it was palpable to all stakeholders so that it wouldn't meet the resistance of its predecessor bills. And finally, we were in a position to then advocate for the for this bill in Parliament. It was actually, by 2014, it was moving to its second or third reading. It was then presented to various Senate and parliamentary committees for justice, human rights, and labor to have further evaluation and consideration and potential revisions. And this is just a picture of myself, the current CEO of Sick Kids, Ronnie Cohen, as well as the then chair of the Canadian Coalition for Genetic Fairness, Bev Haim Myers, in the middle, where we would essentially become a 3-person advocacy group trying to answer questions of these parliamentarians brought together to evaluate this bill, but then also try to advocate for the need for this bill. And so the president of the Canadian Medical Association, for example, Canadian Association of Genetic Counselors and Genetic and Medical Geneticists, we had brought in as many as we could because, of course, then the privacy commissioner and others, human rights and the industries supporting insurance and labor had their own advocacy and lobby groups trying to argue against the need for these kinds of bills and protections. We also undertook a public campaign to try to sway both the medical communities as well as the public to try to speak to their MPs to support this bill. And this is now 2 years later in 2016, 2018. And then fast forward to 2018, where there was a public debate about this bill in Parliament. And Trudeau, as well as his backbenchers, voted against this bill. But despite that, all of the other sitting members of the Parliament across the lines voted for the bill, and it passed. But then, awkwardly, the Liberal government had actually tried to vote it down by actually referring it to the Supreme Court, the appeals court in Quebec, saying that it was unconstitutional use of federal power, saying that healthcare is a provincial jurisdiction matter where federal government cannot really have any jurisdiction or mandate to control. And of course, insurance is also a provincial matter And therefore, this bill actually is unconstitutional. And that's when it was sent to the appeals court in Quebec, which agreed with the majority government position. And then at that point, they had passed it up the chains to the Supreme Court of Canada for a final decision. And again, those of us on the pro side were advocating for making sure that this bill passes after almost a decade now. And I had provided expert testimony at various levels and did so again for the Supreme Court of Canada, which finally actually upheld this law, and it now became the law of the land. So that is a bit of a history trying for me to try to move the needle to remove barriers and access to predictive genomic medicine. But then I realized we had another problem, that as I intimated off the top, when we are sequencing a person's genomic code, we're not only finding the things that we were looking for, but we're also potentially identifying a whole suite of other disease risk for markers, for other disorders, for other disease risks that some of us in the medical community understand what to do with those risks, but other disease risks or these markers or genetic changes are unknown for us to deal with. And the question is, how do we actually mobilize informed consent for patients undergoing sequencing when we can't really a priori determine what they might learn, because we don't know what they harbor in their genetic code, and how do we make sense of all the options that they can learn about, of all the disorders under the sun? And of course, to augment this problem is that we have very few experts on the front line with the genomic and genetic expertise and time and resources to make all of these choices real and describe the risks and benefits for all of these kinds of choices of disease risks for each and every patient. And let's just put this into another case example. Let's back up to the oncologist that is required by clinical practice guidelines now for almost most kinds of cancer to order some form of either tumor sequencing or germline blood sequencing for their patient to first identify what druggable targets are available in that tumor, but also does this patient harbor these genetic mutations like BRCA, BRCA, where I need to actually implement an entire different regime of treatment, including surveillance, screening, prophylactic surgeries, in addition to treating the current tumor that they have. And then how do I make it understandable that in addition to sequencing and screening for what gene mutations or changes occur in the tumor, and also trying to identify BRCA in this particular patient, how do I make the offer available that they might actually be able to learn about other disease risks if they so choose? And again, this person has now just been diagnosed with cancer. So the emotion, the cognitive burden, and the time constraints for oncologists in a 10-minute consult is very real. Let's just put what we're facing in the front lines into context. Patients across Ontario for cancer testing are waiting 6 months. And if anybody has had their own personal experience or an experience of cancer in their families or in their social communities, appreciate that when you're diagnosed with cancer, treatment starts within 1 to 2 weeks. So it is actually inappropriate, but also untenable to be waiting 6 months to get genetic testing. But across North America, outside of cancer, patients are waiting for pediatric or neurological genetic testing anywhere up to 6 months to 4 years, because we simply do not have the professionals on the front lines with the genetic and genomic medicine training to be able to offer this. And our genetic clinics are inundated with 2 to 4 year wait lists. And this is because on your right, the current ratios of medical geneticists or genetic counselors is anywhere between 1 to 100,000 patients to 1 in 300,000 patients that we need to be serving. And this is in the context, this workforce challenge, these wait lists and the limited workforce is now against a backdrop in the center of a 74% increase in the number of genetic tests that are not only available, but are actually expected to be used in clinical practice. So we have a very much a real supply and demand problem. There is a clinical demand, a clinical obligation, and a clinical best practice to be using more genetic testing in order to personalize patients' care, identify if they're at risk for a more severe illness, identify the right treatments to treat them. But we don't have the supply of medical professionals with the expertise, the time to then provide the appropriate counseling and support for patients, not only to support them in making choices, but also the interpretation of those results and the medical management of those results. So that's why, since sort of trying to address the genetic discrimination barrier, I've tried to address the lack of workforce and the lack of access barrier by employing digital tools. Now, this was actually before COVID, and people were looking at me with cross-eyed, thinking, what the hell are you doing with these weird and wacky apps or platforms? And that was back then when I was thinking, okay, well, if we don't have the people in the front lines, and we are now expecting and should be empowering patients in their medical care, how do we do that without data dumping information after they're waiting several years in a high pressure cooker situation and making them sign a consent form and then deal with this onslaught of information that they may or may not be prepared to learn? So when I was a fellow now at Memorial Sloan Kettering Cancer Center, and I was watching the clinics, again, a mass sequencing for every cancer patient, and not having the experts and the genetic counselors or the other medical staff on the front lines to support them, I made it my now postdoctoral project to create alternative medical models, alternative service delivery models, so that we can now deal with this supply and demand problem. We've removed some of the fears around genetic discrimination, and now we've got more of these technologies and tests to offer, but we don't have the folks on the front lines to support them. So I created the prototype of the genetics advisor in New York when I was a postdoctoral fellow. Then when I was recruited back to Toronto, I had applied for funding to then build out that prototype into a full digital platform, co-created with patients for patients as well as their clinicians, to make sure that it was clinically valid, the content, but also serve the needs of what patient needed based on their lived experience of having genetic testing in the past, but also in their current experiences of what is being offered concurrently now and what the clinicians were actually seeing as a future proofed need for going forward. So this is the genetics advisor. It's meant to be both a provider and patient-facing platform to try to deal with that demand and supply problem that I just described. And what it does is that once a patient is offered genetic testing, let's use the oncologist again. The oncologist in a 10-minute consult, after unfortunately just diagnosing that patient with cancer, recognizing this is not the emotional state to then talk about all this extra information, this other testing other than the pathology that's going to be required to diagnose and classify their cancer. They then say, you know, I'd like to offer you the genetic testing. I'd like to know whether or not I need to treat and manage you in a different way based on these results. But I recognize this is a lot to handle right now in front of me. Once you're emotionally settled, when you get home on your own time with the support of your loved ones, please go onto this platform, for which I'm giving you the link from our clinic that has licensed this and is sanctioned this for you to use. Please go and learn about what genetic sequencing and what the results might be and what the implications might be for your medical care, but also the potential implications for your family and their reproductive decisions, their career choices, their educational choices, and those of your potential of your children as well that this might implicate. And sit with that over time, again, at your own pace, and then think through, as a genetic counselor, other medical genetics practitioner would do, is think about the pros, the benefits, and the risks. Think about a day in the life of learning about the fact that you're at increased risk or have this BRCA mutation or this Alzheimer's disease risk that you might uncover, we might uncover. Think through what it is that you'd like to learn, and then also consent through that application online. And so what the actual advisor does is actually simulates a digital experience of what a clinician would go through in a grade 6 level, providing educational opportunities. We all learn differently. Some of us are visual, some of us are story learners. So we provide both videos, we provide patient stories, we provide text with very chunked out high level information, and allowing patients or individuals to go deeper and deeper if they choose to, or stay at a high level to understand the basic concepts. And then in the values exploration and the psychosocial decision support, we go through interactive exercises to get the person to reflect on the risks and benefits and what kind of decisions that they would actually choose. And then in real time, there's an algorithm that reflects their responses back to them to give them a perspective of where they seem to be on a risk tolerance perspective and what subsequent or outstanding questions they may still have to then present back to their clinician before choosing to consent for the test, or if they don't have any questions, they can go on and consent. All the while, the clinician and their clinical team can manage the patient's progress and milestones, making sure they're going through the program appropriately, answer questions asynchronously. And then if the patient has consented, that consent is then sent back to the clinician's team. They then organize the requisition in the lab to actually conduct the testing on that person's tumor or their blood sample that they've left in the clinic or in the laboratory. And then once those results are ready, the clinician uses our patient-friendly templates to explain the implications of those test results. Most often than not, the clinicians are comfortable only returning negative results, meaning there's nothing to worry about. And what they're doing is reserving their precious limited time to sit with the patients who have positive results that they need to then explain. So these are creating efficiencies now in the system and reducing the backlog of individuals that could just be told, you're fine, there's nothing to worry about. This is what it means and this is what it doesn't mean, and have an ongoing record of what that means to share with family members as well, and reduces the burden on themselves as now the patient struggling through cancer treatment or whatever the case may be can have this asynchronous resource to let their family members know, and have an ongoing lifelong record as to if they do have this mutation that they've now learned directly in person from their physician, a plan of what they need to then follow in terms of their treatment regimen that doesn't just go in one year and out the other, but they have a standard resource for them to continuously be empowered and know what they need to follow. And so that is the intent and the way that it is used in various ways across different healthcare settings, providing not only a living record for the patients, but there is a small wrinkle with genetics and genomic science. It is a pretty cutting edge science still, and we are only learning or understand about 10 to 20% of what the genetic code means. And as things get resolved or results get resolved, there's an obligation actually clinically as well as for researchers to recontact research participants as well as patients should there be an update to their genetic test result. And of course, that creates a major burden for both the clinical teams as well as the research teams to go track down these patients potentially months, if not years later. And how are we going to do that at scale? So this platform was also meant to obviate that need by creating a lifelong record to recontact and communicate results to patients. One of the reasons why I developed it and made sure that I took it through and got the Canadian Institutes of Health Research funding that I did was not only to make sure that we co-design it with the end users and their needs in mind, but also take it through the type of rigorous evaluation that we subject any drug, device, or technology in our healthcare system, and also take it to the randomized clinical trials to make sure that not only is it as good as seeing as a clinician, but potentially better. And so I'll go through the actual randomized trial in a moment, but just as a conclusion to keep in mind, we did find through the clinical trial that there's increased satisfaction for patients, improved acceptability and knowledge. It was not only easy to understand, but the use of this digital tool in advance of a clinical consult actually reduced the consult time by over 50%, creating not only both increased patient reported outcomes and experience better, but creating efficiencies in the healthcare system to allow better access for those that need to be seen. So what did we do? In this trial, meant to evaluate the clinical effectiveness of the genetics advisor, we had recruited a population of adult cancer patients from various familial cancer clinics across Toronto who had already underwent first-line genetic testing, but were given a result that was inconclusive. They're either negative, or we didn't know whether to classify them as positive or negative, for whom sequencing would actually be a potential next line test. So we were trying to target and use a patient population that would be as close to using this type of technology as possible. And this is not available at that time yet clinically. And the intervention, we asked them to be randomized to either the intervention arm to use the genetics advisor before a clinical consult, or the control arm, standard of care counseling, which is often on the phone. Excuse me. And our primary outcome of the trial was decisional conflict, which is consistent with what counseling and decision aids usually are powered on. But our secondary outcomes were knowledge, satisfaction, preparation for decision making, anxiety levels, and the acceptability of the tool. So let me just tell you about who we recruited into this trial. We were actually recruiting from a large proportion of breast cancer clinics, so it's unsurprisingly that there was a predominance of females, or those identifying as females in our sample of our trial. There was a relative split in terms of the age, but as with most research, and genomics research specifically, there is a preponderance of those that self-identify as white or European descent, a relatively high education level. Income was rather split, but then, the expected personal family history of a family history of cancer or personal history of cancer as well. But importantly, randomization as expected made the two arms of the study basically no difference in their demographics. But what did we find in the trial? First and foremost, those using the advisor, the intervention arm showed a significant improvement in knowledge on two subscales that we use to actually understand objective knowledge as well as subjective knowledge of the content, as well as a trend towards more satisfying decision-making process by using the advisor. We also saw a sustained level of improvement in knowledge over time that we were actually measuring it through the trial. And importantly, we showed a significant reduction in consult time, again, on the order of over 50%, like I told you, up in advance. Those in the intervention arm using the advisor actually had a 97% acceptability rate, that this was actually appropriate and they'd want to use it for their medical decision-making for incidental or secondary findings. And there was some quotes from participants saying, I thought it was a really good tool. I found it very easy to go through online. I liked going through it online. And, I thought, ooh, am I going to forget everything? But no, I was fine. So here, this participant was explaining or corroborating the fact that they liked the modality, that it was online, and that it was actually triangulating the knowledge improvement, saying that they didn't forget everything, that they were able to actually access that knowledge base. Someone else said, I thought it was good because sometimes when you answer the questions, it sort of made you rethink it or think about what you really understood. And I thought that was good. Now, this person is reflecting on that digital psychosocial counseling exercises that we embedded, making them think and rethink about the pros and cons of what they're about to make decisions about. And again, reiterating that they thought it was good to understand, appreciate what you understood to be the implications and reflect on those going through the program. I have a fairly sizable lab at St. Michael's Hospital comprised of clinicians, genetic counselors, geneticists, as well as researchers in health services and policy. Now, this individual, Dr. Salma Sheikh, who just finished her PhD, is a genetic counselor by profession, came to do her PhD with me. And one of the things that she was interested in evaluating is how do these types of digital tools affect the patient-provider relationship in practice? What are the changes other than improving patients' empowerment and their education and reducing emotional distress in the use of these tools in advance of seeing their clinician? But how do they actually impact that clinician-patient relationship or dyad? So what she did was actually, in her genius, had said, okay, let's audio tape the interactions and the consults between the patient and their genetic counselor in both arms of the trial, the control arm, as well as those that use the advisor genetic digital tool and then speak to a counselor. And she then did a qualitative analysis looking at the transcripts across both arms of the study to understand the nature of the discussions, if they were changing, the amount of discussions that were changing, and what actually was the impact between the patient and the provider across both arms. And what she had found qualitatively was, first and foremost, if you quite literally just glance at the transcripts, the written verbatim recording documentation of those sessions from the intervention arm versus the control, what she literally, you can see the patient doing most of the talking in the intervention arm, talking to their clinician, whereas in the control arm, the patient is being talked to, and their utterances are either or yes, or one sentence, one line responses to the genetic counselor or clinician. Whereas it was actually reversed in the intervention, where the counselor is confirming, yes, that's correct. Yes, indeed. And it's the patient that's doing much of the talking. So her first conclusion at the top is not only it promoted more dialogue by the patient in that dyad, but actually more informed conversation. So promoted engagement by the patient during the course of the session, but also informed dialogue. Second, when she started to realize what was going on in the nature of the conversation, she recognized that in the intervention arm, those using the advisor actually more often were articulating the trade-offs that they're making between and deliberating between the decisions that they were making and reflecting on the harms and benefits that they had learned about in the advisor, but further, not only enhancing that deliberation, but that deepening that personalization of those pros and cons, those risks and benefits into their own lived experiences and their own personal circumstances to then reach some of the decisions that they're making. And for those of you in the audience that come from a clinical background, would recognize that these are the three fundamental pillars of patient-centered care, suggesting that these types of tools can actually promote patient-centered care. So just to rehash, on the trial, quantitatively, we showed that there was improved knowledge and efficiency, but also it didn't come at the cost of patient-centered care. And in fact, these types of tools can actually promote the level of empowerment and engagement and the patient-centeredness of those interactions, even though that they're much shorter in terms of consult time. I have then had the pleasure, after publishing this work, to be approached by various health systems around the world, asking to use this tool in practice. And I was pleased to do so as part of research collaborations with Sunnybrook, with Australians, Murdoch Children's Research Institute in Victoria, the NHS, BC Cancer, UCSF, the VA in California, and Singapore, and other parts of Australia for the oncology community. And we've been able to build on this success and actually adapt the genetics advisor into other in other supportive tools for oncologists, for mainstream genetic testing, in order to promote the uptake of genetic testing among the family members, cascade testing, as well as for in pediatric settings, which require a very different set of sensitivities, both for the parent as well as the child. So we've managed to start to create adaptations of this platform for implementation and use and testing, validating testing through randomized trials in all of these other contexts. But concurrently, we're also doing research with what are the sensitivities of the medical practitioners that are being potentially sidelined by the use of these technologies? What are geneticists' perceptions of the use of digital tools in their practices? And so we've been conducting interviews across the country with both patients and providers, asking for how they perceive the use of these tools and how welcoming they would be in using these tools in practice. And so we have these three themes. First and foremost, they told us, and this is just quickly the sample characteristics of this interview study, was predominantly female, and most genetic counselors, in fact, happen to be women and female. So that is not super surprising. There is, 2/3 of the sample were genetic counselors, 1/3 were medical geneticists, and there was some representation across the regions of Canada and sort of a split across years of clinical practice. So qualitatively, we interviewed these participants, these medical providers, and we did, again, thematic analysis of what the transcripts and themes were saying. So the first theme was this general readiness for digitization. Again, this isn't happening past COVID. So, we have a backdrop of virtualization during COVID of the medical system. So that is not too surprising. But the reason why they were ready was twofold. Providers had favorable attitudes to these tools because they saw it as a way to reduce some of their current inefficiencies in their workflow. They liked the idea of offloading administrative tasks of medical and personal family history that they had to do, or any other paperwork that they had to do. They liked the idea of offloading those tasks onto the platform because it allowed them to then practice at the top of their scope and provide that patient level centered care by the time that they reach the consult with the patient. But they were very clear about the fact that we can't just use these digital tools in any way and at any point, that they particularly found them the most appropriate pre-test before their counseling visit to be able to input their clinical assessment, so personal and family history, to provide that education before the consult and do some of that pre-test counseling and decision support with the patients. They were so that was the green. The yellow is sort of them being sort of hot and cold about the idea of returning results through this platform. And of course, this was context dependent. In the pediatric space, they were less comfortable returning these results. In the cardiology or oncology space, they felt a bit more comfortable. But then there was some gradations, like I said up the top. They were very comfortable returning negative results because those results could be understood. But when it came to positive results, there was, again, this case dependency. So that was unpacked through these interviews. But there was definitely a no-go, a red zone when it came to post-test counseling and management, where the clinicians really felt that they wanted to retain that under their clinical practice, and because of the individual level care that was required. But most interviews ended around these more philosophical or system level issues, that they would reflect on this important considerations, we called it. One, they would reflect on the shift of their own role in clinical practice by the incorporations of these tools, and wondering, okay, where is my professional role, medical role now vis-a-vis these tools? And then second, head scratching that they would do at the end of these interviews is questions about equity. And then on the one hand, we're able to increase access potentially by creating these efficiencies in the workflow and potentially through the clinic. But on the other hand, are we just actually widening the digital inequities and access issues? And so here's a quote. we're patting ourselves on the back saying, look at all these new patients that can access our service. But we're still excluding the same population that we've always been excluding. And we're not really achieving equity, are we? And that's very important to think about, because obviously there's various different forms of equity and inequities, whether geographical inequities, whether they're racial or other disparities. But there's also digital disparities in terms of folks' willingness or comfort using these types of online tools, whether they even have access to broadband or Wi-Fi in certain under-resourced settings. And we also have probably heard in this space about some of the biases that are inherent into our data sciences that get unfortunately reinforced and reified when we use AI. Now, of course, these tools are only as good as the data that we input into these tools. And if that data is inherently biased, which unfortunately it is, then we are only going to be reinforcing those inequities using these tools. So really be thinking about carefully, not only just developing and co-designing these tools and just throwing them into practice, but thinking about what unintended consequences we're actually leading to. So we've argued that, on the one hand, there is definitely this need to be careful about evaluating and considering these equities, but these digital tools can advance the quality of our care, this patient-centeredness, and potentially equities, because there is broad ancestral groups that have been shut out of our health systems, as well as in the digital science or digital systems that we use that are going to be reified. But if we can access these individuals that are distrustful of the medical system, are living in rural or remote communities that have otherwise limited access to the health system, these tools can actually extend an olive branch and a lifeline to get them the care that they need in an asynchronous or synchronous fashion. We also have seen from inside genetics and outside and other medical disciplines that the use of these virtual or digital tools, whether they're decision aids, chatbots, software systems, or even games, can actually improve patients' knowledge, can improve their understanding of the next steps for their care and their adherence actually to screening, surveillance, and treatment recommendations. And in fact, as I've just mentioned, we could be deploying these services in underserved communities and actually engage non-genetics professionals or non-experts and support those experts in the communities to serve those underserved community members as well. But we need to attend to diversity in both in the design and the deployment of these tools. And one of those ways to do so is ways that I've described off the top, by co-designing these tools with the end users at the table, not coming a priori with some widget that some commercial provider has thought this would be the panacea and answer, but sit there as equal members of the decision-making table with those that are meant to use those tools as patients or as providers to ensure that they are being developed and deployed in ways that are going to actually support their care. And what does co-design mean? It means literally ideate. Blank slate, blue sky, what is your need? What are your lived experiences? What are the roadblocks? And what are your concerns in employing some of these digital tools or other low-tech tools? Design them with the user experience in mind, prototype them, and then usability test and refine them with those end users. But also consider, when attending to diversity elements, what the context and clinical capacity really is. So context from a patient or community's perspective, they might not have broadband access, or if we're talking about low resource communities or countries, they might not have smartphones. So in addition to these high-tech opportunities, we need to be thinking about low-tech options as a coupling with these tools, providing patient summaries, employing these tools at kiosks, at the library, or providing iPads at the clinic so that we can overcome any of these technological barriers. Culture is a very important issue to attend to in the co-design and deployment, making sure that cultural norms around medical decision-making, whether those decisions are taken as an individual or in some communities taken as a collective, as a family decision, can be also baked into the co-design and the way that these tools are implemented in practice. Some individuals are not comfortable with computers or digital tools, and making sure that we have navigators or other community partners that can help use those tools collectively with those patients and their families. And of course, cultural competencies, making sure that the risks and benefits that we as a medical community are attuned to some of the risks and benefits and how they're conceived of by that community member. We might think about a pedigree or a family tree in one respect, but some communities and cultural groups think about families as much broader than biological ties, and have to be reflective and respectful about the way that we're conceptualizing and reflecting on some of the information that we're both sharing and what we're requesting from them to give us. And clearly having multiple languages and making sure the digital and health literacy is taken into account as well. But then finally, thinking about the workforce that we are deploying these tools with. We've seen probably you've heard about a lot of medical administrators that sort of left right after COVID, when there was this onslaught of other virtual and other administrative tools that are being used. And frankly, it was just overwhelming and burdensome for a new crop of, or a current crop of administrators to essentially take on and retool and upskill themselves with. So we have to be careful as to not overburdening our medical professionals as well as the support staff around them with yet more administrative burdens, and considering the workflows. When in fact is it appropriate to use these digital tools? You know, using it before a consult, after a consult, during the consult, really being sensitive to the clinical context, the emotional burden of that patient at that time, and the cognitive burden for the patient as well as the provider in how we actually deploy these tools. This is work that was spearheaded by these graduate students in my lab, trying to provide a framework for others that are digital tool developers to be attentive to in the development, evaluation, implementation, and iteration of these tools in practice, so that we can be thinking about these at all levels of and all phases of the co-design and deployment. And this is especially important from an equity perspective, because unfortunately, there are significant racial disparities and ethnic disparities into who actually is able to access our clinical genetic services now. There are significant barriers for racialized and minoritized individuals to accessing healthcare writ large, and specifically for cancer genetics or clinical genetics specifically. And this is against a backdrop of pre-existing structural racism in healthcare, the existing patient-provider distrust in healthcare, as well as the unfortunate history of eugenics in clinical genetics. But there has been over a decade of research, mostly in the US and starting to creep up in Canada, that shows that there are significant disparities for racialized and minoritized patients in who gets referred for a genetic test. Black patients, Black women specifically, are 16 times less likely to be referred by their family docs because of a suspicion of a genetic disorder for clinical genetic services. And we can be talking about why that is, whether that's just training, whether the fact that our medical textbooks are filled with images and cases from white and European ancestral communities, or just structural racism. But the facts is that a Black woman in the US is 16 times less likely to get a referral for genetic testing. Now, going down the clinical pathway, there is even a disparity in getting testing. because in our provinces and in certain states and Medicaid or Medicare will only cover testing for certain indications with certain background risks. And so the likelihood of certain racialized patients knowing about their family history, sharing that family history, the family myths about family history, or having the time to take off work to go and access a genetic test is much reduced among those who are of non-white and European ancestry. And then further down the line, if you manage to get yourself a referral for genetic testing and manage to get yourself a test and get through those barriers, the unfortunate issue, like we were talking about the data biases in the system, also implicate the way that we interpret a test result, because the databases that we use to interpret genetic test results of normal results versus pathogenic results, disease causing, is rife with data from individuals of European and white ancestral communities, making it very hard to interpret the genetic test, whether it is actually disease causing or not, from those who are non-European ancestry. So the likelihood that a person of racialized, minoritized background of getting uncertain results back, gray zone results back, are even higher for those. So they've already dealing with barriers, getting access to genetic testing, getting a genetic test, but their likelihood of getting a clear-cut molecular diagnosis from a genetic test once they clear those barriers is actually lower than their white counterparts. And clearly, if you don't have a molecularly confirmed diagnosis, then you're shut out from secret high-risk screening programs, surveillance strategies, and prophylactic interventions that would actually lead to reduction in their mortality and morbidity. So it's also unsurprising that those of racialized and minoritized backgrounds are actually suffering from higher mortality rates from a range of conditions, and in this case, various cancer types. So we have to recognize, especially in a much more, cutting edge science like genetic and genomic medicine and sciences, that the paradigms of clinical practice and research are inextricably linked. They're inherently linked, such that the disparities that we're seeing downstream in our medical practice are very much connected to the upstream practices in our scientific enterprises. If we're not including these racialized and minoritized populations in our data, in our research databases, in our reference databases, which is what the case may be, you can see that European ancestral groups are disproportionately highly represented in our databases to interpret genetic test results compared to those of East Asian and all other ancestral groups. And that proportion has not changed over time. 96% European ancestry, 81% European ancestry, and just 3 years ago, still 86 in the 80% ancestral group. If we're not changing the needle, moving the needle as to who is welcome and participant in our research, which is so linked to our clinical care, then we're not going to be moving the needle. So the next area of research that we're working on now is to not only support ways that we can deal with some of these disparities and barriers clinically, but also be thinking about how scientists and researchers in the scientific enterprise can actually be more inclusive of these communities and have them more involved in our clinical trial and our basic research as well. But this also requires a paradigm shift, because I don't know about you, but I wasn't necessarily trained about how to meaningfully and respectfully engage underrepresented groups in my research, and how to do that in a way that doesn't further create distrust or tokenism in the communities. And if we want to be respectful and actually change the tide of the distrust in the medical or research enterprise among communities that do not want to participate in research, but are inherently disadvantaged clinically because we don't have their communities' data and perspectives baked into our research data, then we're just perpetuating the problem. I'm getting a timeout. Okay. Amazing. So I'm just going to wrap up and say that there are significant opportunities to advance patient-centered care and share decision-making and improve wait times and efficiencies, but there are systemic barriers and disparities that exist in our healthcare systems that may actually be perpetuated using digital tools. And one of many ways that we can be thinking about how to do this properly and appropriately and responsibly is by co-designing these tools with those communities that are underrepresented, as well as their medical providers, to ensure that they're deployed in ways that we can continuously learn and iterate and improve on those over time. I just wanted to thank a huge group of professionals and trainees in my lab, my co-investigators, as well as my funders. Thank you.